right, welcome back. Sorry for a little bit of delay, just troubleshooting audio here in the room. So welcome back. I have the pleasure of introducing our next speaker. Dr. Elizabeth Tyler Cavara is our Chief of Pediatric Neurosurgery. She did her undergraduate at Duke and was a biomedical and electrical engineering major, which I didn't know before this. And initially worked as an engineer before going to medical school at Vanderbilt and doing neurosurgery residency in Pittsburgh and further training in Alabama. She came to us 4 years ago, and I'm excited to introduce her as our next speaker to talk about how best to access and what a pediatric neurosurgeon can do for the pediatricians. Thank you.
Thank you, Al. All right, this is going to be a little weird for me because normally I would be pacing back and forth, but one, we're broadcasting this, so I'm supposed to stay close to the microphone, and two, I can't walk very well right now. Sort of the premise for this is that, we've always wanted this symposium to be a way to impart information to the people we work with. And I realized that when I was in Pittsburgh, and I had been there for more than 20 years, most of the pediatricians that referred to me, I had either gone to school with, or I had known for a decade, or they had taken care of my daughter, and everybody had my cell phone. And so I, in many ways, was the neurosurgeon on speed dial. And when I moved here, it is sort of rebuilding all of those things. And we have had neurosurgery speak at this symposium multiple years, but I really wanted to just boil this down to what are sort of some of the top 5 questions that I have been asked over the years. And let's see if we can get this to go to the next one. And we found the missing audio that I need to delete out of the talk. I have no financial disclosures. I have a new disclosure that is not one that most people care about. In moving to the world of putting our talks up on YouTube and things, people want references to every single image that is in there. So the images in this date back more than 20 years. Some of them have subsequently been posted to the web. We have done our absolute best to identify what the current best known source is, but many of these have come out of file databanks from residency, from fellowship, from attending. So we have done our very best to do this. So what have been those top 5 questions? I think one of the big ones is the head too big? And what is fascinating to me is, depending on where you are, the kid with a big head gets sent to all sorts of different places and gets all sorts of different things done. So I am going to take a few minutes to really address that one. The other one, which goes a little bit along with the head too big, is this a funny-looking kid? And sometimes that is the parents think that the kid's a funny-looking kid and that the head's just not right. Sometimes it's the pediatrician. Sometimes it's the grandparents who are really pushing for this. And we'll do a quick run through that. One that we really spend a lot of time with in the NICU, but I think also then becomes something that lands in the pediatrician's office with newborns, is there's something funny on the back of this kid. Do we need to do a spine MRI? Do we need a spine ultrasound? And we will go through a little of that. And then the other question I think that I frequently get is, who needs an MRI? So we're going to go through sort of the red flags for back pain and the red flags for headaches, to just sort of try to simplify what's the best way to do this. And then the last thing I'm going to do, which is not on the summary slide, is I'm going to give you some ways to contact the pediatric neurosurgeons here so that you never feel like you have to wait to obtain an answer. And I'm only doing this because I'm really serious. If you have a question, we want you to reach out to us. So here's the first one. Is this head too big? So if we age correct this child, it is not so much looking like they're crossing percentage lines. But if we look at them, they continue to get bigger and bigger. So is that head too big? Well, we're gonna look at a little bit of that. So what are sort of the differences between benign macrocephaly and hydrocephalus? Because usually that's what people are worried about when we're worried about the head being too big. So we know in benign macrocephaly, the problem is usually that actually there are increased subarachnoid spaces. And I describe that To parents, in a simplistic way, is that the box grew before the brain did, and we have to fill that space with something so the subarachnoid spaces expand with spinal fluid. And that's probably not the correct pathophysiology, but it makes it easy to explain. Obviously, in hydrocephalus, we typically have enlarged ventricles. Many kids with big heads will have soft, depressed pulsatile fontanelles, while as the kid with hydrocephalus often has a tense, bulging fontanelle. You don't see distended scalp veins in kids with macrocephaly, except maybe if they're throwing a temper tantrum. Whereas you will often see very prominent, particularly across the forehead veins in the child who's got a big head because of hydrocephalus. The other thing is if you put your hand on those kids' heads who have hydrocephalus, often you can feel a space between the coronal sutures, along the sagittal suture, less so in the lambdoids, whereas in benign macrocephaly, there is no splaying of the sutures. The kids with macrocephaly typically get observation, whereas if they have hydrocephalus, we're absolutely going to move to CSF diversion. Benign macrocephaly has all kinds of names. Some I like, some I don't. The one most commonly used here has been BESI, or benign enlargement of the subarachnoid spaces of infancy. Before I came to Austin, that was not a term I had ever used, and so it took me a while to figure out what the heck BESI was, but now I know. I'm not really a fan of benign subdural collections of infancy because now that we have high-resolution MRIs, we know that in benign macrocephaly, it is really the subarachnoid spaces that are enlarged. Benign subdural effusions, similarly, it's not really a subdural problem. Benign extraaxial collections, hypodense extracerebral fluid collections, idiopathic external hydrocephalus, which I hate, benign hygromas, and subarachnoid effusions, which is probably also an appropriate term. So what does this look like in the patient? So this is that growth chart I showed you before. So this child looked like they were crossing percentage lines, and they had a CT scan which showed these extraaxial collections. It can be very difficult to determine whether or not these are subdural or subarachnoid on a CT scan. This kid was referred to us at this point, and we age corrected and went, well, you know, they're not really crossing percentage lines too crazy. Let's see how this goes. But they decided to keep growing, and so they got, you know, a good 2.5 centimeters above the 97th percentile. And we got this MRI, and on this MRI, and I'm gonna see if I can get the pointer to work, I hope that you can appreciate that there's a little line here, which is really the outside of the subarachnoid spaces, and that there are actually bridging vessels in here. And this is a beautiful example of this being the enlarged subarachnoid spaces. This kid, as you can see, sort of finally started tracking back towards the curve, and somewhere along the line, we finally got mom and dad's head circumferences. I'm going to tell you, finding the head circumference charts that go out to 20 is actually a real challenge. I now have a laminated one in the clinic. I actually have hat sizes marked on the side so that if you've got a parent who's not around, but we know a hat size, which here in Texas, people actually know their hat sizes, so that we can make a really quick judgment. And so you can see this kid, dad's head circumference was, I think, 5 centimeters above the 97th percentile, or 95th. Mom's was right at the top. So this kid was just going to have a big head. And so that is very, very typical. I now make sure we get a parent's head circumferences on the first visit, because if mom and dad's heads are giant, I can usually say, we are in a good place, we can send you guys back home. But here's another good example. This is a kid, you can already see that they've already plateaued and coming forward. And while they have a little bit of an expanded space, it's not very much. This is really typical for what we see, is that somewhere around 12 to 15 months for these benign macrocephaly kids, that they tend to sort of start to turn back towards the curve. So we put together a little bit of a simplified algorithm. I have not put this in as an EBOC here at Dell Children's, but if anybody wants to volunteer to do that on the pediatric side, maybe I will recruit a pediatric resident to do it. If the OFC is crossing percentage lines or has already increased above the 97th percentile, and it is out of proportion for the parents' heads, that is probably a point where it is reasonable to obtain imaging. Today, most often, we would do a fast MRI because it gives us more information. And head ultrasounds, unless they are done specifically looking for extraaxial collections, don't do a good job of showing us those extraaxial collections. If it's normal, and that's great, then, and if there are signs of increased intracranial pressure or not, if they're not, then we'll just follow those kids. If, on the other hand, there are signs of increased intracranial pressure, then that definitely becomes a reason to refer to neurosurgery. If you're following them and they continue to keep growing, again, I would say that's a good reason. I used to sort of pull the rug on about 3 centimeters above. Now, particularly if parents are 3 to 5 centimeters above the curve, I will often wait till about 5 centimeters. All right, now I'm gonna flip to does the kid have a funny shaped head? This kid's got trigonencephaly. I'm gonna tell you that I've gone from a world where we operate on these kids and now we don't. This is, the trigonencephaly is early fusion of the metopic suture, shown here in blue. The metopic suture fuses in all children by around age 2. Early fusion can give you a very trigonencephalic head. There have been a lot of studies looking at whether or not these kids have decreased skull volumes. There's some stuff coming out of Europe that says they really don't, and the majority of these kids by the age of 5 to 6 actually look really normal. So living someplace where every kid who had a metopic ridge was being offered surgery in the next state over, who would come to me and I couldn't even figure out why this was being offered, because in Pittsburgh, we almost never did this, to someplace where kids had very, very pinched temporal lobes and really were pointy, and in particular had hypotelorism, we would consider it. And so, but this is becoming less and less common of a procedure, although in kids with really significant hypotelorism, we will do it. So how do you tell the difference between positional plagiocephaly from back to sleep versus craniosynostosis? We know that positional molding tends to improve with repositioning, whereas with premature fusion of the sutures, typically it is getting worse over time. Molding helmets are really controversial in many places, and we know that in mild and moderates, we probably don't need to use them. Many people, because of the cosmetics, still recommend them in severe. The kids with positional plagiocephaly have normal ICP. Some of the kids with craniosynostosis, certainly the multi-suture ones, will develop increased ICP, and we now know that a fair number of single suture synostosis, if it is coronal, lambdoid, or sagittal, will also. And we know that positional plagiocephaly is significantly associated with torticollis. So this is a kid with positional plagiocephaly, flat on the back, the same side is pushed forward. You can't see his ears. So this is really sort of a parallelogram type position. If we look at lambdoid synostosis, which is one of the more difficult ones to see, you see that the side that is flat, the ear is actually pulled back. And this is where there's fusion on one side of the lambdoid suture really pulling everything back. And these are often the kids who will get put in molding helmets and we don't see any improvement, and then they show up in the craniofacial clinic. Sagittal synostosis is pretty straightforward. It's premature fusion of that sagittal suture. So instead of getting growth laterally, you get growth in the long direction, and so these kids end up with very long-shaped heads, either referred to as dolichocephaly or scaphocephalic. I think the unicoronal is probably the easiest to recognize. So this is premature fusion of one coronal suture, and you get that eye pulled up or on an X-ray, a harlequin sign. We do also see bilateral coronals. This is often syndromic, and these kids just tend to have a really short head and high. All right, so now we're going to move on to all those kids with funny things on their butt that you don't know whether or not they need to be imaged. I'm going to make it really simple. If it is a dimple that is more than 2 centimeters below the top of the gluteal cleft, it is almost certainly not pathologic. Now, that doesn't mean if you go scan 1,000 kids with one of those deep sacral pits, as we used to call them, that you aren't going to find somebody who's got abnormal imaging. But in general, those kids are not found to be pathologic. And that is what this image is up here. Now, if you have a divot like this, which is a dermal sinus tract, above the gluteal cleft, here's one that has a hemangioma around it. Here's another one that's actually quite small and difficult to see. Those are absolutely concerning for dermal sinus tracts that go all the way to the spinal cord. And those are going to be best imaged with the MRI because ultrasound will not always pick up the dermal sinus tract. We know that occult spinal dysraphism can be a cause of neurologic compromise from tension or traction on the spinal cord, and that if children develop deficits, they can be progressive, and if we do not disrupt that pattern by releasing the cord, we can see progression of those. We know that if we have severe deficits, they are unlikely to recover back to normal, which is one of the reasons we care about this. So there are a whole host of cutaneous signs, and I'm just going to show you some pictures to try to give you some ideas about this. These are some patients that I've taken care of in the past. These are dermal tails or lumbar appendages. So a true lumbar appendage actually has muscle, bone, and cartilage in it. They often have reflexive movement, but you can also get skin tags that look very similar as you see here. If you have a rounded lump that is skin covered, that is most likely going to be a lipoma. They are often asymmetric. Again, those typically extend into the canal and cause tethering and need to be addressed. These are much less common, and these are from images collected for talks when I was a fellow. This is what's called an atretic meningocele. So this is an area where things didn't quite close, but we have a little bit of abnormal skin. Some people refer to it as looking like a cigarette burn or abnormal paper. This is a classic meningocele. This is one of my patients before we did surgery. And so this is skin covered, but this is fluid filled. And you can tell that it's fluid filled because it's jiggly. Again, these often need to be treated because they can be associated with a fibrous tract that's causing a tethered cord. And then, of course, this is the classic open meningocele, which I do not think is something that we miss. It is fascinating to me that in some countries, these are still not closed because the resources just don't exist. And some of these children really do go on to survive into adulthood. We talk about hemangiomas. The hemangiomas we care about are the ones that are over the lumbar spine. If there's one up on the shoulder or on the thoracic spine off midline, those are not the ones we care about. The capillary hemangiomas shown here, which are the flat ones, can fade over time. The infantile hemangiomas, which often require treatment with dermatology, can also be associated with a tract that extends to the spinal cord. These we also recommend imaging. Often these are identified in newborns and ultrasounds can be done. If those are normal, we can sort of move on. If they're not, then we probably need an MRI. The other things that are not concerning, I mentioned that these pits, but the cafe au lait spots are not concerning. And I think a big area of controversy has been the wide or the deviated gluteal cleft, and there has not been shown to be a significant association with tethered cord with those. All right, now I'm going to move into those big red flags. You got a kid who comes into the office with back pain. The guidelines for MRI would say they need 6 weeks of physical therapy before they qualify for getting an MRI. When do you need to find a way to get around that? If somebody presents with back pain, particularly that wakes them up from sleep, you need to be worried about a mass lesion in the spine. If they have new onset of constipation or they're having difficulties urinating, you need to be worried about a mass in the spine or something compressing the conus. If they have developed new weakness or changes in their gait, because sometimes a family will say, hey, they're not weak, but yet if you ask them about their gait, there's been a significant change in their gait. Those would all be red flags to obtain an MRI. And we are absolutely open if you have that kid and you don't want to do the MRI, is to call us and we will get them in through our same-day appointments or help expedite doing that. We are absolutely happy to do that. All right, so then when do we order a brain MRI? The most reliable thing that I have found over the years to make me really worried about increased ICPs is the kid who wakes around 3 to 4 a.m., pukes, feels better, and goes back to bed. That is very classic for increased ICP, and that kid probably warrants imaging. If we have new neurologic deficits that don't occur during a headache to suggest they're part of a complex migraine, so changes in gait, new weakness, changes in vision, those are all absolutely 100% red flags. Now, the change in vision might be that they just need to have their eyes checked with the ophthalmologist. They are also very, very quick to say, hey, this is something that needs a scan. If you have new seizures with any of the above changes, again, we worry about some sort of lesion that is irritating the cortex. Now, the other one that comes to me all the time is, oh my goodness, this kid's got a Chiari. Usually that's a read on an MRI, but the kid who is having Valsalva-induced headaches, so they scream every time they try to have a bowel movement, they can't participate in sports anymore because they get a terrible headache at the back of the head. Little kids who are running around playing and suddenly scream, grab their head, sit down for 5 to 10 minutes, and then are fine and off and running. Kids who have developed sleep apnea, the kid who is snoring and pausing, who does not have big tonsils, is probably of big concern and would often get a sleep study and imaging. The kid who has developed an inability to swallow thin liquids. So the kid who is fine, and now all of a sudden is coughing and sputtering every time he drinks his milk or his water, or her water. The other thing is the child who has developed a nasally voice. So I had an 8-year-old who came to see me in clinic who now had this like crazy nasal voice that was brand new. And the parents like, oh, we just thought he was going through puberty. Well, you don't usually get an awful nasal voice when you're going through puberty. You get more of the typical cracks and squeaks. So those I think of as sort of the big red flags for needing a brain MRI. And again, like I said, if there is a question, we are always happy to get those kids in and evaluate them and help expedite doing the MRI. All right, now, I'm going way out on a limb here, but it needs to be done. And I did check with Dr. Iqbal on this. All right, this is my work cell phone. Feel free to snap a picture, write it down. If you have a question, text me, call me. If I don't answer, leave me a voicemail. This phone gets taken care of because it is my work cell phone. I'm not going to give you my home cell phone because my husband will lose his mind. I very carefully asked Dr. Iqbal which phone number he wanted me to put up. This is the phone number he asked me. Again, same thing. You can text, you can call, you can leave a voice message. Now, if it scares you too much to call one of us, you can always call a clinic. This is the clinic number. If you hit option 3, that will put you to the back line. I have actually tested this to make sure that this actually puts you through to somebody to answer the phone, and it does. Otherwise, I wouldn't put it up. The staff in the clinic will make sure that the call is routed to either one of the APPs or one of the attendings, and we try very hard to make sure that this is answered on the initial call so that we can help answer the questions and expedite the care for these children. And with that, I would like to say thank you to everybody who has helped with the care of all of the children here in Central Texas, and I'm open to questions. I scared everybody away. That means I have us back on time. You do. Oh, I got one.
Thank you so much for a great talk. One question for the pediatricians who are in the room, do you ever recommend they go ahead and order imaging if they're concerned about head size, for example? And if so, what should they be ordering first?
Yeah, so if you're really worried about hydrocephalus and the child's fontanelle is still open, it is perfectly acceptable to get a head ultrasound. And if the ventricles are normal, then you've got a good answer. In a kid who you're more concerned that you need to reassure everybody that this is really benign macrocephaly, because the subarachnoid spaces are often not well shown on an ultrasound unless the ultrasonographer knows specifically that that's what they're supposed to be looking for, a fast MRI is perfectly acceptable. When I first moved here 4 years ago, really the only place we could do a fast MRI was here at Dell Children's. I believe we have certainly rolled out fast MRI protocols across most of ARA. I haven't seen any from Longhorn yet. So they are available more readily than they used to be, and that is definitely an option. You can also just call us and ask us to see them, and we'll take care of it. All right, thank you, everybody.